Hello, everyone. We're going to go ahead and get it started. Thank you so much for joining us today. My name is Erin Tinnen with the National Center on Domestic Violence, Trauma, and Mental Health. We will be providing technical assistance for today's webinar. Today's webinar is new updates on how the Affordable Care Act can help patients experiencing domestic violence and interpersonal violence, sponsored by the Family Violence Prevention and Services Program, the Office on Women's Health, and Futures Without Violence. Our presenters today will be Mary Louise Kelly, Director of Family Violence Prevention and Services Program of the Administration for Children and Families, Sabrina Madoff-Stepp, PhD, Director of the Office of Women's Health, Health Resources and Services Administration, Lisa James, Director of Health, Futures Without Violence, and Lena O'Rourke, O'Rourke Health Policy Strategies. Before we get started, I'll go over some of the technical details of the WebEx software that we will be using for today's webinar. Many of these details are also explained in the Using this WebEx System tab in the upper left-hand side of your screen. Please be aware that your screen might be looking a little bit different depending on whether you're using a Mac or a PC. On the right-hand side of the screen, there are multiple boxes. The second from the top is the chat feature. This feature will allow you to provide feedback and share resources with your fellow colleagues, as well as get in contact with trainers or myself if you have any questions regarding the training content. You may contact Jennifer Curley with the National Center on Domestic Violence, Trauma, and Mental Health if you have questions troubleshooting the WebEx software. To do this, click the down-facing arrow and select the person you would like to contact. You will see a lot of options, but for this session, you will want to select all participants if you'd like to respond to a question from the trainer or contact me anytime during the session. You should click on Jennifer Curley to privately contact her if you're in need of troubleshooting the WebEx software. So let's test this chat feature. Will everyone please go to the chat box, click on All Participants, type in the organization that you are calling from, and then press Enter. Excellent. Perfect. Thank you all so much. You can continue to put in your organizations if you like. While folks can get a lot out of the chat feature, there are times when it moves really quickly and can feel a little bit distracting. If this is true for you, you can feel free to minimize the chat box by clicking on the arrow next to where it says chat. You can always open it again with the same arrow if you choose. We will be doing some polling during this webinar as well, and the results will show up below the chat box. At the end of the webinar, you'll be taken to a very brief evaluation. Please take a moment to let us know what was useful and what could have been better. If you get disconnected at any point, you can return to the email you received with the original webinar link and re-enter the training. Sometimes the sound cuts out due to the internet connection, so feel free to call into the conference line if that's a problem for you. If you're experiencing technical difficulties and are unable to contact Jennifer Curley, you may call WebEx Tech Support to resolve any additional issues. That phone number is 1-866-229-3239, and we'll post this number and the number for the conference line in the chat box. A link of the recording of today's webinar will be available on the Futures Without Violence website. It can take up to 24 hours for it to become available, so please look for it tomorrow. Futures will also send a follow-up email to let you know when it's available. Again, thank you so much for joining us today, and I will now turn the training over to Mary Louise Kelly, the Director of Family Violence Prevention and Services Program, ACF.
And great, thanks for unmuting me. And thank you all for joining us, and I would welcome everyone to please continue to add in the chat box the program that you're calling in from. It's great to see people from across the country and to find out what backgrounds people bring to this discussion. We're really happy to be co-hosting this webinar. This is a great time for this work at the intersection of domestic violence and healthcare. And we thank you for joining us on the webinar, Updates on How the Affordable Care Act Can Help Patients Experiencing Domestic and Interpersonal Violence. As Erin mentioned, I'm Director of the Family Violence Prevention and Services Program, or FVPSA for short, and we're in the Department of Health and Human Services, Family and Youth Services Bureau. And this year we're celebrating the 30-year anniversary of the FVPSA program. It was the first federal funding source for domestic violence programs around the country, and it's a very exciting milestone that we're celebrating. And it also says that that's the perspective I'm coming from as I talk with you here today, is speaking to you from this network of domestic violence services that we support around the country. And it consists of the local shelters, over 1,500 shelters and 1,100 non-residential services programs, state and territorial domestic violence coalitions, over 200 tribal domestic violence programs, the National Domestic Violence Hotline, and a network of 9 national and special issue and culturally specific resource centers, one of which is the Health Resource Center on Domestic Violence. You'll be hearing more from them today, and also the National Center on Domestic Violence, Health, and Trauma, which is helping to host the webinar today. So all of these programs around the country are serving over 1.3 million victims of domestic violence and their children every year. And in addition, the National Domestic Violence Hotline is fielding calls from more than 22,000 callers each month. And so that's a broad scope of work that's reaching people who are reaching out for help through domestic violence programs at the local and the national level. In the past couple of years, the Affordable Care Act has really expanded our options and opportunities for reaching survivors of domestic violence who may seek help a little earlier before someone might come to a domestic violence program, and hopefully to prevent future violence. The Affordable Care Act includes coverage for screening and counseling for domestic and interpersonal violence as a preventive health benefit for women during their preventive health care. The ACA also improves access to care for victims of domestic violence and their families, allowing them to enroll, and we'll speak to that a little later in the webinar as well, some of the healthcare enrollment opportunities. So more than ever, healthcare providers are in a unique position to identify abuse, and many of them feel as though they could benefit from training on assessment and referral and protocols for intervening in domestic violence, because healthcare providers can hesitate to screen or do assessment if they don't know where to turn if a survivor discloses. So that means partnerships with local domestic violence programs, state coalitions, and the hotline are really critical to support the work of healthcare providers and help them to be a gateway for services and help for victims of domestic violence. The state domestic violence coalitions and state agencies that distribute Family Violence Prevention and Services Act funds can be a great point of entry for accessing training and technical assistance and connecting with local domestic violence programs that can be partners in this work with healthcare providers. So looking forward, the VIPSA program intends to continue to raise awareness through webinars like these, by distributing guidance and supporting training and technical assistance, such as that done by the Health Resource Center on Domestic Violence. We're also working very hard in partnership with our colleagues across the Department of Health and Human Services to work on interventions, research, training, and coordination across the department. And you'll be hearing soon about some partnerships with the Health Resources and Services Administration when Sabrina Madoff-Stepp discusses their work. So want to share with you some resources that we have developed over the past year, frequently asked questions that healthcare providers may have or domestic violence advocates may have around healthcare and its connection to victims of domestic violence, special considerations, and also a fabulous resource that the Health Resource Center has developed, which you'll hear more about, the Health Cares About IPV online toolkit that supports the work of advocates and of healthcare providers in promoting screening and counseling for intimate partner violence. Our FISB website, the Family Violence Prevention and Services section at the Family and Youth Services Bureau website, is a great place to access ongoing tools and resources, grantees that I've described, and I welcome you to take a look at that ever-changing resource for up-and-coming news. And on the occasion of our 30th anniversary, I want to welcome you to visit the Learn About FIPSA website, and which reflects on the work that has been accomplished through the domestic violence movement and FIPSA's involvement and support of it over the last 30 years. And so now I would like to turn this over to my colleague and friend, to Sabrina Madoff-Stepp, who is the Director of the Office of Women's Health at the Health Resources and Services Administration. Sabrina.
Thank you so much, Mary Louise, and thank you to you all on the phone who are participating this afternoon to join us for this webinar, and greetings to my friends and colleagues out in San Francisco, Lisa and Lena. I'm really pleased to be sponsoring this webinar this afternoon with ACF, with my colleagues in the FIPSA program, to highlight again the very, very important issues around domestic violence, screening and counseling among populations that we all serve. I serve as the HRSA, the Health Resources and Services Administration's Office of Women's Health Director. In this capacity, we work across all of HRSA's programs to integrate women's health into policy, programming, and education. We look at our role as really a cross-cutting role to make sure that the programs that HRSA receives funding for are taking into account the important work that all of us are doing. And right now we have domestic violence and interpersonal screening and counseling for domestic violence as one of our top-tier priorities. So why is this issue so important to HRSA? HRSA's priorities include access to care, developing and supporting a health workforce, and improving health equity. Many of HRSA programs support serving populations in underserved communities. HRSA has responsibility for the safety network of health centers across the country. HRSA also supports health provider training across academic institutions in both urban and rural communities. HRSA also supports the National Health Service Corps, the Nurse Corps, and the Ryan White program that serves patients with HIV and AIDS. And in all of these programs, across all of these very, very important programs, we are trying to move the needle and hopefully improve outcomes, health outcomes, quality of life for patients. Part of how we do that is looking at all of the factors, all of the sociodemographic factors, all the social determinants of health that may impact reaching those outcomes. And increasingly we're seeing that unless we take into account the impact of domestic violence and IPV, we may not be moving the needle as quickly as we'd like. So in my capacity over the last couple of years, I've really seen an opportunity to work across the aisle, to work with my colleagues and other agencies, to work with state, community, and other partners to raise attention so how we can integrate looking at domestic violence as not just an outcome in and of itself, as important as that is, but as an issue that really needs to be looked at as one of the variables that may be impacting other health outcomes such as diabetes or heart disease or depression and so on. As Mary Louise mentioned, domestic violence screening and counseling is one of the Women's Preventive Service Guidelines under the Affordable Care Act. HRSA has the distinction of being attached to those guidelines. As you all may know, they are officially referred to as the HRSA-supported Women's Preventive Services Guidelines. So we are very much involved in making sure that both providers and consumers are aware of those guidelines and how they can take advantage of them in terms of communicating about them and their availability to women across the country at no additional cost. I'm really excited this afternoon to share with you a new opportunity that we are just beginning. Mary Louise alluded to this, that involves our health center program. HRSA's Health Center program has grown from 17 million in 2008 to almost 22 million patients in 2013, and 59% of those patients are female. In 2013, health centers served nearly 10 million women aged 15 and older. That's more than 3 out of 5 of all health center patients in that age group. So the pilot project that we are beginning in 2014 is a pilot to look at how to work with 3 health centers in terms of how they can begin to train and integrate screening and counseling for domestic violence in their actual health center. Across the board, there are some health centers that are already doing some screening and counseling, but it is not standard, it is not universal, and there is no existing measure for that particular clinical outcome at all HRSA health centers. And our goal, and my personal goal here, is to make that happen. So we're so excited about this partnership with ACF, with our colleagues in the HHS Office on Women's Health and with our colleagues here at HRSA to begin that process and to start to see how we can develop models for other health centers to do this kind of very important screening and counseling. So with that, I think I will stop, and I'm going to introduce our speakers this afternoon, and I'm very, very privileged to be able to do that. I'd like to introduce Lisa James, the Director of Health at Futures Without Violence, and Lena O'Rourke of O'Rourke Health Policy Strategies. As Director of Health, Lisa has collaborated with healthcare providers, policymakers, and domestic violence advocates in over 25 different communities. She coordinates the National Health Resource Center on Domestic Violence, Project Connect, and the National Conference on Healthcare and Domestic Violence. Lena O'Rourke is founder and principal of O'Rourke Health Policy Strategies, which is committed to developing and implementing good public policy on healthcare issues with an eye toward making our nation's healthcare system work. She serves as an advisor to Futures Without Violence on the Affordable Care Act and domestic violence. And so it's my pleasure now to turn it over to Lisa and Lena.
Thank you so much, Sabrina and Mary Louise, for the introduction and the introductory remarks. It's a real privilege for us to be able to co-host this webinar and talk a little bit about the Affordable Care Act and some specific provisions around domestic violence and interpersonal violence, and really the opportunity for improved partnerships between domestic violence programs and healthcare programs so that we can better improve the health and safety of our patients and clients through violence prevention. So we got a little peek at this with the introductions, but I'd like to take a moment to do a quick survey and get a better sense for those of you on the phone, if you could tell us a little bit about who you are, whether or not you're a healthcare provider by clicking on the A in your chat box, whether you work for a domestic violence or sexual assault advocacy program, or a health administrative or policy, health policy professional, or other. So if you could just go into your chat and click on the letter that corresponds with your profession, we would have a good sense of who we're talking to on the webinar. So I'm just going to click mine and submit. Okay. Just take a couple more minutes. Okay. Great. Thank you. There we go. Now I'm seeing the results. All right, great. We have a good mix. That looks like a really good mix of both providers and advocates and administrators, which is perfect because I think some of the materials that we're going to be talking about and sharing with you today are relevant for each of those groups. So as Mary Louise and Sabrina mentioned, we here at Futures Without Violence host the Health Resource Center on Domestic Violence, and what that means for you is that we provide free technical assistance and materials for both patients and providers and advocates on how to improve the healthcare response to violence. So at the end of the webinar, we'll have a couple of slides that talk in a little bit more detail about those materials and how you can access them. And what we hope to cover today during the webinar is really talk through the importance of health coverage for survivors and victims of violence and how critical it is to make sure that they've got that health care access given what we know about the health consequences of abuse. To talk again about the specific provisions that were mentioned in the Affordable Care Act and other health policy recommendations that are specific to domestic violence and interpersonal violence, and to walk through just the kind of key components of a comprehensive response, healthcare response to domestic violence. And we are really seeing a huge influx and change in the major shifts in terms of health policy responses and practice responses to domestic violence because of the Affordable Care Act and other new practice recommendations. Here at the Health Resource Center on Domestic Violence, we've seen a significant increase in requests for training and materials from both advocacy communities and the healthcare community. So we really see this as an unprecedented opportunity to build on the changes and improve the health and safety of women and families who are experiencing abuse. But I want to back up a little bit and talk about why we're seeing this major shift in terms of the healthcare response to violence. And that is because over the course of the last decade or so, we've seen a significant increase in research that's really pointing to the long-term health consequences of domestic violence. And you see on your screen that when we first started this work 20-plus years ago, most people across the United States really thought about domestic violence in terms of broken bones and black eyes. And sadly, while that still is true, we're also really understanding the long-term impact of violence and its impact on a whole host of chronic health issues, such as asthma, cancer, hypertension, and depression. And truly, some of the largest health problems that our country is facing today, there's direct correlations between exposure to domestic violence. And that's really why we're seeing a shift in the healthcare system on the importance of responding to violence in their setting. We've also learned through new research that studies are showing that women support screening and assessment for domestic violence in the healthcare setting, if done properly and respectfully. There also has been found to be no harm in assessing for domestic violence in the healthcare setting. And emerging research is showing that interventions improve the health and safety of women. And that's what I'm most excited about in terms of the possibilities to not only decrease risk for violence, but also improve her health and wellness and making sure that the patients and clients that we're working with are really thriving. Unfortunately, we also know through our death review teams and homicide review teams that when we don't ask, we have some truly fatal missed opportunities, and that women do fall through the cracks of the system, and that women are regularly seeking health care services prior to circumstance of homicide. So it's all of that data put together that has truly moved the needle in healthcare settings, and one important piece in addition to the Affordable Care Act is the U.S. Preventive Services Task Force recommendation that now supports, they've found that there's sufficient evidence to support domestic violence screening and intervention, that's actually an effective intervention and preventive health service. They're a very deliberate body of researchers. They review the research, and again, this is a relatively new recommendation that there's sufficient evidence to support screening currently they're recommending that for women of childbearing age, which they define up to 46 years. They did find, however, that there was insufficient evidence for elderly or vulnerable adults, and we know that there's such an overlap between elder abuse and neglect and intimate partner violence that we really are working to galvanize more support for new research in this area so that we can move through and make recommendations around screening for elder abuse as well. So, as was mentioned in the Affordable Care Act, as of August of 2012, health plans must now cover screening and counseling for lifetime exposure to domestic and interpersonal violence as a core women's preventive health service. So we're going to talk a little bit about what that means in just a bit, but it is a pretty significant change and coverage recommendation. It's not necessarily a requirement for providers to screen, but rather when they do screen, that it must be provided free of charge, and the insurance companies must cover that benefit. Also very important was, because of the Affordable Care Act, insurance discrimination against victims of domestic violence is now prohibited. And so insurance companies are prohibited from denying that coverage to victims of domestic violence as a pre-existing condition, which many of you in the domestic violence field know we really have been facing for decades now, that problem, and have had a state-by-state response. So this is really critical and important shift as well. We're going to take a pause and do another survey, because I'd like to get a sense from you all how or if you've had seen any changes in your programs or your practice as a result of these recommendations. So if you have seen any increased referrals, if you're a domestic violence program from healthcare providers, or vice versa, from healthcare settings to domestic violence programs. Have you seen any increased referrals? Or have you seen an increased request for training? Again, in either direction. Are your healthcare settings asking you to train them on domestic violence, or as domestic violence programs, are you getting increased requests? So take a moment to fill these in. And lastly, whether or not you're seeing some new or building new partnerships between your local programs as a result of these recommendations. If you have anything in the other category, please do feel free to enter that in your chat as well. We'll take just a minute to let that come through. As you take a moment to fill in the survey, I will say, just in terms of the work that we do at the Health Resource Center, and what we've heard from coalitions and domestic violence programs across the country, is there hasn't been a huge increase in referrals as of yet of patients from healthcare providers, but there has been an increase in training requests. Okay, so I'm just getting the results, and yes, this is what we're experiencing on the national level as well, that you've seen some requests in training, and for those of you who answered, not a huge request in training or referrals or new partnerships. What we're hoping to see in the next couple of years is a real increase in those new partnerships between healthcare and domestic violence programs, so that you can cross-train each other about the services that you provide and truly provide the best care possible for clients and patients in your program. So we'll talk in a little bit about what that looks like. Thank you. So before I turn it over to Lena to talk about the new provisions in more detail, I just want to acknowledge that these changes, both the task force recommendation and the Affordable Care Act, do have implications for the domestic violence programs. And what that might look like, we are, as you saw from your own survey, is it's really evolving. It could result in increased referrals eventually from your healthcare programs. It could definitely increase your requests from your healthcare programs around training for around domestic and sexual violence and the services that you provide. It can also result in unintended consequences. If providers are poorly trained or not trained at all on how to ask that question, or not understanding the reporting requirements, there really are some unintended consequences if folks are not adequately trained of these new recommendations. And that's why it's so important that you all have joined us today to talk through some of those the elements of that core training and the resources that are available. But what we've also seen is that it has definitely made an impact in terms of forming new partnerships between healthcare programs and domestic violence programs. And that's really what we want to see, as I mentioned before, so that we're reaching more women and families with prevention and intervention messages. For advocates, I know here at the Health Resource Center, we are looking at ways that this might eventually create new funding streams. So, for example, who can be reimbursed for that brief counseling, and can an advocacy program be reimbursed by the healthcare program for the brief counseling if the referral is made? So there are a number of us who are working across the country to explore models for reimbursement and other funding streams to support what we do believe will be increased referrals and strain on capacity. Similarly, we know that healthcare providers, and this impacts you all as well, and again, it might mean for you that there's an increased need for training on how do you screen and what does screening look like and what does a brief counseling entail. And understanding that, like domestic violence and sexual violence advocates, there's an incredible demand on your time and how you can fit this in on top of everything else that you're doing. We talked a little bit about the unintended consequences, but again, we're really hoping that this webinar and the resources that are referred to here will help you to think through how to do this effectively and safely and form new partnerships to reach patients more effectively. So with that, I'd like to turn it over to Lena, who's going to talk a little bit more about the ACA and how to get covered. And actually, if you guys could pass the ball for me, I'm not seeing that part of my screen at the moment. Just one second. Here we go.
Wonderful. Thank you, Lisa. And thank you to all of you for joining us this afternoon. And good afternoon. My name is Lena O'Rourke, and I have the job today of explaining just a little bit about the ACA and what it means. And my goals are to explain what the key health insurance coverage options are, and what that means for the people you serve, to make sure that within the context of the health insurance coverage world that you have enough of a framework to talk about insurance options, to explain to you how you can actually help people either get coverage or get to someone who can help them get coverage, and to talk a little bit about what coverage means for survivors of domestic and interpersonal violence and what the new screening requirements are. So with that said, let me jump in. We are, as everyone before me has so eloquently said, at a really exciting crossroads in which the Affordable Care Act has made health insurance coverage available to millions more people, and the plans that are being offered cover a really comprehensive set of health benefits, which include medical and behavioral health services. And open enrollment to either get new coverage or to renew your existing policy starts on November 15th this year for open enrollment. It's a lot like open enrollment you'd have in a job-based plan. It's for people who need to either change their plan, they already have one through the marketplace, or they need to buy a new plan. And again, open enrollment starts in 2 weeks and 2 days on November 15th, and it goes through February 15th of 2015. So it's a 3-month period where people can go in and either pick a plan or renew their existing plan. And that's for coverage that begins in 2015. So this webinar could not be better timed to make sure you have the tools you need at your fingertips to help people get insured. So what are these coverage options? What can someone go out and buy for themselves? There are 3 new programs or improved programs to get health insurance. The first is the insurance marketplace. That's the healthcare.gov you've undoubtedly heard about. We'll get into more about what that is in just a second. But so there's the insurance marketplace, there's Medicaid, and then there's the Children's Health Insurance Program, or CHIP. Depending on the individual's circumstance and their family size and their income, people will qualify for different programs and with different financial help to purchase that. Significant financial help is available to the private market coverage through the insurance marketplace, and that's based on family income and size. So the marketplace itself is really just a new way to buy private health insurance. Some states have chosen to run their own marketplace, and others have had the federal government run their marketplace. Under either circumstance, you can go to healthcare.gov and figure out what your state has done, and it will link you to the application you need. What the marketplace does, I think, that is really cool is it allows an apples-to-apples comparison of the plans so that you can look in your state and in your region and see what the different options of coverage are and at different levels of coverage. You can upgrade your plan to one that has more comprehensive coverage. You can look at the different options and see really what's available to you and what best fits you and your family's situation. It displays all the costs up front, and the plans are mapped in such a way that they're comparable. So you can look at the plans and see what they're offering. To be eligible to purchase coverage in the marketplace, you do have to be a citizen or a national of the United States, and you can't be incarcerated. The federal subsidies are available based on a sliding scale, and as I said, that's based on family size and income. Of note, legally present immigrants, including those who are subject to the 5-year immigration bar, can buy insurance through the federal marketplace. They are not prohibited from purchasing coverage in the marketplace. Medicaid is the second big bucket of coverage, and the ACA has created new opportunities for states to bring more people into their program, and many states have chosen to expand Medicaid dramatically, resulting in huge numbers of people becoming eligible for coverage. Medicaid plans do cover the Essential Health Benefits Package, which includes all of the comprehensive women's health screens that we've talked about earlier today, and we'll get into more later. Medicaid enrollment is open all year round. You can apply at any time for Medicaid enrollment, and you are screened for Medicaid enrollment when you go to healthcare.gov through the marketplace. It'll tell you how to get into Medicaid. So that is open all year and is a coverage option. CHIP, the Children's Health Insurance Program, is also open all year for children and in some states their families, and that eligibility is year-round as well. Medicaid eligibility depends on which state you live in, so I can't go through what the eligibility levels are for each state, but in general, the opportunity now exists for states to expand to people at or below 133% of the federal poverty level. And children are already covered at that, but it ensures that they remain covered at or below, and in some cases above, 133% of poverty. Of particular note for this group, former foster care children are now eligible through Medicaid even after they've aged out, up to age 26. And members of tribes are eligible for Medicaid based on their state's existing Medicaid decisions. So whatever the income threshold is for Medicaid eligibility, that applies to the members of tribes as well. You'll see that I keep going back to open enrollment and the date, and I'll probably say it 5 more times here. Open enrollment starts in just a few weeks. To begin an application, you'll go to healthcare.gov. You'll put in your state, and that will help you figure out how you apply for your state's marketplace. Again, I continue to direct people to these dates because there are only limited opportunities to enroll outside of open enrollment. I do want to call attention to those just briefly, but let's keep focused on this wonderful opportunity for open enrollment in front of us. Members of tribes may enroll at any point year-round. There is no open enrollment period for members of tribes. Medicaid and CHIP enrollment is year-round, and there are some life changes that trigger enrollment outside of open enrollment, such as having a baby or moving to another state. But the vast majority of enrollment will happen over these next 3 months. There are, and thank you to everyone who tirelessly advocated to help work this through, special enrollment rules for victims of domestic violence. This is simply a way for people who've experienced domestic violence to access the financial help that they need to purchase coverage. So for people, and this gets technical, it's written there, but we'll step through it, and I'm happy to answer questions on it as well. For people who have experienced domestic violence who are legally married, but who live apart from their spouse and plan to file their taxes separately, they are able to access financial help based only on their own salary. The healthcare.gov application is a little bit funny. If you are legally married, it actually makes you put in both spouses' income. But for this population, we know that they are not able to access their spouse's income. So we've created a special way for them to enroll. There's no documentation needed to prove that you have experienced domestic violence in order to do this, but you will have to attest to it on your taxes when you pay your taxes at the end of the calendar year. So if you fit those qualifications, if you're legally married, you live apart from your spouse, and you plan to file your taxes as separately, you should mark unmarried on your marketplace, your healthcare.gov, your marketplace application, even if you are legally married. And what this does is it allows the system to award you financial help and to do your eligibility determination based only on your income and not your spouse's income that you no longer have access to. I know that's going to feel a little bit funny. People will be counseled to mark unmarried, but both the IRS and HHS have put out guidance saying that this is what to do. And that really is the rule, as funny as it sounds, to check unmarried on your application if you fit those criteria. It will, again, not ask you to prove domestic violence, but you will have to attest to that on your taxes the following year. It is important to note that there is a tax penalty for people who remain uninsured. You do have to buy insurance. However, people who have experienced domestic violence who remain uninsured, who are not able to buy health insurance, are eligible for a waiver. It's called the hardship exemption. And the application can be found at healthcare.gov, and you can file that along with your taxes. No documentation is needed to prove domestic violence in this case either. It's a really simple and subtle form. It is important to note, though, that you would still be uninsured and not have access to the vital health care services that you get when you are insured. But this provides a really nice policy option for people who are in transition or for a variety of reasons are not able to purchase health insurance, that they do not have to pay the tax penalty if they have experienced domestic violence. And again, that form can be found on healthcare.gov as well as more information about the exemption. The slide available now is one maybe to print out and put on your bulletin board. This is how we can help direct people to enrollment and to get to the application. Healthcare.gov is where you can find the application. It's also available in Spanish. The call center application number, the call center application center number is also on the board. And also here is one resource I'd really like to push you to look at, the Find Local Help. There is an amazing network of in-person navigators, marketplace guides, assisters. They call them all sorts of different things across the country, but every state has a network of free in-person help to help people navigate the application and to get them enrolled. If you go to localhelp.healthcare.gov and put in your zip code, you're able to identify some of the people near you. And these are trained assisters who have gone through guidance. They will understand the application, what information is needed. For people who have experienced domestic violence and are interested in applying, as we just discussed before, they'll know the rules and can provide some really good and competent help to navigate the application process. So as you're looking for ways to help clients looking for coverage, keep these numbers handy. They'll be able to help guide you to places, to where people can apply and to get coverage. So I am curious, as we go through this sort of at breakneck speed, how many of you have shared information about the domestic violence, I'm sorry, the question's a little unclear, but have shared information with women in your program about the Affordable Care Act and about the ways people who have experienced domestic violence can get coverage? Let's see if we can get the poll up here. All right, so maybe this isn't a poll. Maybe use the chat. Folks should use the chat. Jen has just put into the chat. Please use the chat feature as we go forward. We'd love to hear your experiences about how you have shared information about the Affordable Care Act. How are questions coming in? And if you didn't know where to go, what types of resources would be helpful to you as we try to make the linkages between the programs you work in and getting affordable health coverage? We encourage you to use the chat and share some of your experiences and answer any questions. In the meantime, I'm going to keep going because I want to transition now to what having the coverage. So you get your plan, you go into the marketplace, you get your plan, you apply for Medicaid, and you're covered. What does that mean? What is this screening benefit? Plans are required to cover, quote, screening and brief counseling for domestic and interpersonal violence. As Lisa said previously, and I know we got a question about already, this is not a requirement that providers screen for domestic violence. Rather, it's a coverage requirement. Insurance plans must reimburse providers who do the screening and brief counseling. Coverage varies by state and by the actual plan, but the benefit is available to all people in these new coverage options. There are no limits to what the benefit can cover. Insurers go plan by plan to define what the benefit looks like and what is actually covered in the new DV and IPV screening and brief counseling. They do give a little bit of guidance. The screening may take place anywhere. They do recommend it as part of the women's health, the Well Woman Visit, which includes a lot of preventive services. And HHS suggests that it can include, quote, a few brief and open-ended questions. We do have sample tools available and ways to do good screening. But again, there are no limits to what the benefit can cover. It will depend on the individual plan that is covering the person to set the rules. Similarly, brief counseling is up to the plan on how it defines it. HHS has said that counseling provides basic information and referrals and tools and safety plans, and that at least once a year it can take place, but there are no restrictions on what the brief counseling can cover, and there are no restrictions on the number of times a plan can reimburse for this service. The plan can define what it looks like and how that works, but it gives a lot of flexibility in terms of how this can be administered. The last thing I will go through, and then we'll turn back to what a comprehensive response will look like, and we'll turn back to Lisa, is who can bill for providing screening and brief counseling. And of interest, there's no limits on the types of providers who can be eligible to provide the screening and brief counseling. It is subject to the state law in terms of licensing and scope of practice. And providers have to have a formal relationship with their insurers, including the Medicaid program, to be able to bill for the service. You have to be a licensed provider in order to get the reimbursement. But there are no limits as to what that means in terms of what the state and the plans can make eligible and who can be a member of the care team and who can be reimbursed. So there's an opportunity for a wide range of different types of providers to do the screening and the brief counseling. And with that, I'm going to turn back to Lisa to continue with the presentation. Lisa, I think I've turned that back over to you.
Great. Thank you so much, Lena. Okay, so as Lena described, we really have an opportunity to shape how this looks in practice because so much is up to the individual plans. We as healthcare providers and domestic and sexual violence prevention advocates can really work together to make sure that we keep the focus on a patient-centered and comprehensive response. So for example, when we first started hearing about responses to the coverage recommendation and the task force practice recommendations, we here at the Health Resource Center started getting a lot of questions about what's the one evidence-based tool or screening tool that we can put into our electronic health record and call it a day. And we're really working at the Health Resource Center with a variety of state coalitions on domestic and sexual violence, healthcare providers and plans, and public health programs to make sure that we do focus on this comprehensive response so that we're really meeting the intention of these new policy shifts, which is to protect, to promote the health and safety of patients and clients that we serve. So we're really looking at how providers can do all of the elements that you see on your screen, which is be sure to review limits of confidentiality before screening for domestic or sexual violence. So that varies state by state, and I'll talk a little bit more about that, but making sure that providers know what their state reporting requirements are and stating right up front what those limits of confidentiality are prior to screening. And at the Health Resource Center and at the online toolkit that Mary Louise referenced in the beginning, we have sample scripts for providers on how to do to review those limits of confidentiality quickly and efficiently. And then we really want to be sure to work with providers to address the health-related issues and address the reason for the visit in a trauma-informed way. And I'll talk a little bit more about how that looks different with each visit, but we're really focusing on the opportunity to respond to the reason why she came in and the health issue at hand in a way that takes into account any experience of trauma or domestic or sexual violence that she is experiencing. And then again, where reporting is required, to do so in a way that is most supportive of the patient and to provide documentation and promote privacy of medical records as much as possible. So each one of those elements, is absolutely critical to a comprehensive response to domestic violence. And as I mentioned, I'll put a link up at the end of the presentation with tools to help you address each of those issues. I wanted to spend just a little bit of time around the screening question because, as I mentioned, we definitely know that there are a number of validated assessment tools like the abuse assessment screen that have shown that they're effective in increasing disclosure rates. And many of those tools are being integrated into electronic or written records in terms of either the patient fills them out themselves or the provider fills it out with the patient. And what we are really seeing in the field as the most effective approach is some combination of those two things. So where there might be some prompts in either the electronic records or in screening questions on the intake forms, it's absolutely critical to combine that with a discussion with the patient that is specific to the reason for his or her visit. So when I talk about visit-specific or patient-centered assessment, we're really looking at starting the conversation less around, have you ever been hit, kicked, or slapped by your partner, but more about why are they in to see the healthcare provider that day, and how can they address that specific health issue in a way that's trauma-informed. So through the Health Resource Center, we've created a variety of different brochures that help providers get at this more visit-specific or patient, what I think is a patient-centered approach that really gives them the tools to have the conversation that complements any other kind of assessment tool in your intake forms. Because it's really critical one thing to ask the question, but what we've seen, sadly, in some cases is that providers don't respond to the response on the intake form, and that's, definitely not what we're after. We really want to make sure that the providers respond if she or he discloses abuse, and then again address the health issue at hand. So we have created a number of different resources for individual settings, and really that response looks different, as you can imagine, for different visits or different settings. So for example, with adolescent health, there are some very simple and straightforward recommendations that can be made around anticipatory guidance for young people about what a healthy relationship looks like. And so we have some resources for adolescent health providers on how to do that, and then also follow up with a direct screening question about whether or not something is happening to them in their relationship. Also, in mental health or behavioral health settings, we have resources that really connect the data and make the connection with the patient and the provider between the connection between domestic violence and a whole host of mental health or behavioral health issues. For primary care settings, we're really looking at offering an intervention that discusses healthy coping strategies to the abuse that she might be experiencing. So, many of you who've been working in the field of domestic violence know that perpetrators of abuse often use a whole host of controlling behaviors, and that includes controlling medication adherence. We've heard from many women that their partner might withhold their asthma inhaler or withhold their insulin. So again, knowing about a current experience of domestic violence can help the provider make a medication management plan that's trauma-informed and will really promote her health. When I talked about harm reduction, one of the things I wanted to share with you is that we've got some very promising evidence of an intervention in reproductive health settings where, again, if somebody directly asks about whether or not their partner is trying to control their birth control or try to get them pregnant when they don't want to be, that has been a very effective way to start the discussion around domestic violence and, again, offer birth control that cannot be interfered with. And, of course, in urgent care, that's much more where we, I think, started 30 years ago, is around safety planning and lethality assessment. And we're really working with people who are at immediate crisis and risk. So this just gives you a very brief example of what we mean when we talk about visit-specific or patient-centered approaches. But we have found a phenomenal shift in terms of how providers respond to asking about abuse and how patients respond as well when we take this more patient-centered approach. So I wanted to just share that with you, and anybody who has further questions, definitely don't hesitate to contact us, and we have a number of resources that are available to help really craft that patient-centered assessment and response. We also know from decades, really, of work in this area with a number of statewide and community-wide partnerships that have occurred across the country, that the partnership between advocates and healthcare professionals is not new, and much of it that has occurred in the past is really informing the work and the strategies that I'm sharing with you today. So you see a number of different programs that have occurred, as I mentioned in the beginning, in multiple states across the country. And it's those experiences with advocates and with healthcare providers together that are really informing this comprehensive response and the elements of a comprehensive response to domestic violence. So I want to give the survey a try again here and see, I'd be really interested to know whether or not, again, we got a little bit of this before, but do you currently have a partnership between your health care program and your domestic or sexual violence program locally? So if you could just enter in the polling question, yes or no, if you're currently partnering with your health care or domestic violence program locally. I'll give you all a minute to fill that in. Takes just a few seconds to come up. As we wait for the survey responses to come in, I'm going to talk a little bit more about what those partnerships can really look like and how we can improve them and expand them moving forward. So great. It looks like the majority of you who responded have said yes, and some are yet to make that partnership. And so one thing that we'd really love to see, if there's one thing you leave this webinar today with, is to reach out to your domestic violence program if you're a healthcare provider, or reach out to a local healthcare provider if you're a domestic violence program, and start to build those bridges. Because given these new recommendations, we're really going to see more screening, and we want to make sure that the healthcare setting knows about the services that are available in the community. So we talk a lot about a warm referral, because I think for many programs there is a resource list. It might not be updated, it might be 10 years old, but there is a resource list of the local community-based services that are available for referral. And one thing that we're really working on with providers across the country is to make sure that, first of all, that referral happens right on site if a person discloses abuse, that you can put him or her on the phone right in the clinic and offer to talk to a local domestic violence program for support. And we've seen that to be absolutely critical because, for one, we know that perpetrators of domestic violence tend to monitor cell phones and monitor what kind of calls she or he is making. So it's important to have that private space to make the call, and also just to offer it right there so that she can act on it while in clinic. And some folks prefer to call the national hotline. They might like a more anonymous approach. So we really recommend offering both the national hotline and especially in programs that are very rural, who might not have a local program, as well as the local community-based agencies. And really getting a sense of not only just referring to them, but knowing what is the services that are provided there, what languages are spoken, and truly making that warm referral. So you're not just handing a phone number, but you're saying, I know this wonderful person, Kate, and she really knows understands what you're going through. Can I connect you with her now? I wanted to just mention and say a little bit about mandatory reporting. We do have some states, each law differs state to state, and some require reporting for intimate partner violence and others don't. And each law has a very unique and specific elements. So it's important to review your state law, and you see here a link on our website where we have a compendium of state statutes and policies on domestic violence and healthcare, including reporting requirements. And again, making sure once you know those laws, disclosing any limits of confidentiality prior to screening. Where you do have to report, we really recommend that you involve the patient and let them know that you have to make that report. And we have a number of different tools and resources and scripts to help providers conduct more trauma-informed reporting. And in some states where there is very strict reporting laws, I know that many providers are recommending universal education. So they're talking to all their clients about violence and not necessarily doing that direct screen. So again, universal education scripts are available through our Health Resource Center as well. Finally, I just wanted to talk a little bit about the codes that could be used to cover screening and brief counseling. So when we work with our professional health associations on this issue, the first question that they've asked, of course, after the DHHS recommendations on covering screening and brief counseling is, what code should I use to document that the service was provided? And as of yet, there is no procedure code that's specific to domestic violence. So many of the organizations, such as the American Medical Association and ACOG and the Academy of Pediatrics, are looking at existing codes for that brief counseling procedure. And so you see on the left-hand side of the slide some preventive medicine service codes that a number of providers are using to capture that the brief counseling service occurred. along with diagnostic codes that have been in existence around domestic violence. And these codes can be accessed in our online toolkit as well. So if you get questions about what codes to use for the counseling provision, these codes are available to healthcare providers. So that kind of goes through the key elements of that comprehensive response from an individual level. But I also just wanted to let you know that other resources are available to support the systems changes that we know are really important to supporting individual providers and advocates and really making sure those partnerships are sustainable. So again, from the practice and the data that has come out over the course of the last 20 years, we really know that changing the environment and something as simple as putting up posters and cards in waiting rooms can really foster a sense of safety and facilitate a discussion around domestic violence. So making those shifts are important. And of course, it's critical to train the providers around how to ask and respond. And again, a number of those resources are available to you. There are a number of patient education tools like the safety cards that we featured that can really be used both as a screening support, but also one thing that we've found in the work that we've done in both adolescent health and reproductive health settings is we started off offering one card for each client and talking through, again, how violence might be impacting her health in that visit-specific manner that I talked about earlier. But we've moved now to offering at least two because so many of the patients have asked for extra so that they could share with their friends or family members. So again, that those patient education tools can really lend themselves to peer-to-peer education as well. We definitely recommend that healthcare programs have a multidisciplinary approach to this so that everybody in the clinic, including the front desk staff, know what the new protocol is around assessment and response, and that the local domestic violence programs are really seen as part of that care team. And so there's a whole host of resources available to you that can help you develop those policies and procedures and really guide some measurement to measure your success in this area on our website, healthcaresaboutipv.org. We also have learned over the course of this work how important it is to make sure that you're offering resources for employees. For so many years, we started to train providers on this issue. The first place that we came back to is that many of the people working in the clinic also have in the past or currently experiencing domestic violence. So again, it's important to have those workplace policies internally and making sure that you have strategies to respond to current experience with domestic violence or the kind of vicarious trauma that comes up with doing this work on a regular basis. So we don't have time on this webinar to go into that, but I did want you to know that there are resources available for you in that area as well. And this is the place where you can go and access all of these resources, healthcaresaboutipv.org. It has a number of different levels on the website where you can really access information by setting, such as reproductive health, adolescent health, or pediatrics, by a specific tab for materials for advocates, and also a lot more information and tools about kind of starting this work and the kind of key protocols and policies that you can take a look at if you want to begin this work in your setting. So with that, I just also want to mention that you can order these materials free of charge thanks to the support of the FIPSA office and Shondell and Mary Louise Kelly. We are able to disseminate those materials free of charge, as well as respond to any kind of technical assistance questions that you might have as you start to do this work. Please don't hesitate to call us or email us. We'd love to hear how it's going in your communities and respond to any questions that you have. So I'll end by just a couple of next steps for both providers and advocates. And the first one really is to, if you don't already, to locate and get to know your local domestic violence provider. If you don't know, you could always call the national hotline and they can point you to your local resources, but we really do encourage you to reach out and begin making those partnerships. You can also order and take a look at those patient and provider materials that can help you create that supportive environment, again, free of charge through our through the Health Resource Center on Domestic Violence. Take a look at your reporting laws and just start to do the work. We really found that once you begin, it's hard to get this going. It's hard if you haven't screened for domestic violence in the beginning to begin these conversations. But once you do, we really found that it can be integrated in a way that's effective and efficient. So begin those conversations and provide those warm referrals to your local programs. I want to just say that we're interested in knowing at the Health Resource Center how it's going in terms of the coverage requirement. So if you ever have any barriers to coding for domestic violence using those preventive services, do let us know because we're trying to monitor that implementation as well. And finally, for advocates, as Lena mentioned, we have this great opportunity to shape the response from plans in your local health plans. And so we just encourage you to reach out and offer yourself as a trusted resource because you know best what the services are in the community and can really help inform the work that they do around screening and response. So there's a whole host of opportunities with the Medicaid director and insurers and administrators if you have the capacity to reach out on that level. And again, on our on the advocate page of the healthcaresaboutipv.org, there are some resources available to give you some talking points on doing that work as well. So with that, I think we have time for questions or comments from the group. So please feel free to enter. I see there's been a lot of chat, so I have to catch up with it, but we'll start with some direct questions, and then we'll take as many as we can get through. I want to just respond to the question from Mary sometime back asking about whether or not the ACA requires physicians to screen. And I know we did cover this, Lena covered this, but I just want to make sure you know that it's not a screening requirement, but rather it's a coverage requirement. So that's an important distinction, and you should know that if the providers screen, the plan is required to cover that at no cost to the patient. But what we've been seeing at the Health Resource Center is really an increase in requests for training and materials on how to do this work because of the ACA and the task force recommendations coming together. It's really been a sea change in terms of how providers are responding. So it isn't a requirement, but many people are seeking information on how to do so. So I'm just taking some new ones from Joanne. Will the fact that screening and counseling happened be kept confidential from a billing statement and on your explanation of benefits? Great question, Joanne. There is actually out of Massachusetts a really nice one-pager which we can send out after this around recommendations to make sure that no information about documentation that screening or disclosure happened gets sent home on the explanation of benefits. So we also have a short policy recommendations for those of you who are working in this area, which we can send out afterwards as well, and it's also available on our website, that goes through what is sort of the brief steps and recommendations around keeping documentation, particularly in the electronic health record, as safe as possible and as confidential as possible, and definitely working to make sure that none of that communication that goes outside the healthcare setting to make sure that that domestic violence is considered sensitive information. So please do take a look at the materials there around those recommendations as well. Let's see. Catching up on some of these. Are there validated scales for sexual or physical violence in the workplace? That's a great question. I don't actually know the answer to that. I'll ask Shondell and or Mary Louise whether or not you know that. Otherwise, I can definitely check with my colleagues here who run the Workplace Resource Center on Domestic Violence, and we can check in on that. I know there are certainly questions, but whether or not they're validated scales, I'm not sure. Shondell or Mary Louise, are you aware of any of that?
We are not aware of any validated scales. There are certainly sample policies and questions that individuals utilize. I agree that the Workplace Violence Response Against Sexual and Domestic Violence Resource Center would be the best place to consult for any samples of validated screening tools.
Great, thanks. Again, from Joanne, I see that there's a question or a comment really around whether or not there's a code for assessment or universal education. And that's a good question. I know that most of the plans or the professional health associations that we've been working with have indicated that mostly they do not need a code for the assessment or the screening because that's part of their they can integrate it into their usual health assessment, but it's the brief counseling piece that needs a procedure code that is missing from the CPT code. So, but universal education might not fall under that, and I would say that the preventive health service codes that were put up and that are available online would also do the trick there, and I definitely would welcome feedback from the field if there has been a problem with that, using those codes for universal education and response moving forward. Lena, I'm going to turn this one over to you. What happens if the abuser still plans to file taxes as married filing jointly? Will this penalize the victim?
Thank you, Lisa. I am not a tax law expert, so let me start by saying that. The rules are actually still sort of in flux on what's going to happen at tax reconciliation time and how that's going to work. My short answer is no, it should not, because she will have, the victim will have filed their taxes according to their situation and will be able to document that in the case of an audit. It would be on the abuser who would not have filed correctly, which you do have to file according to the law, and he would not be because she'd be filing separately, so he should as well. Again, that gets into tax law and not just this. I think the risk would be if it would flag an additional audit and what that would mean. She should not be, the rules make pretty clear that she would not be penalized, financially penalized for receiving the subsidy, even though she is married. So the rules cover the financial penalty for the fact that she's married but receiving the financial subsidy. I don't know what would happen if that increases the risk of audit. Futures and others in the last round of comments to the IRS have put in suggestions that this exemption, the DV exemption, should not trigger additional audits. But I know your question is asking something different. What if his triggers an audit? And I'm really not clear. But I do believe that the way the rule works, she'd not have to be penalized. She would not be penalized for receiving that tax subsidy. But those other pieces are a little unclear to me. I'm not sure, Lisa or others, if you have any additional information or thoughts. We could certainly think about that a little bit more. It hasn't happened yet. You know, this will be the first year. So it's still a little fuzzy to me how some of it works because I don't know the tax policy as well. Yeah, I don't think I have any more other than you just added, but it's definitely something that we can keep our eye on moving forward. I wanted to, let's see, I've lost it here.
I think it was Lisa Adams who asked whether or not the information is available only for women experiencing domestic violence. And the recommendations through the Affordable Care Act and for the task force were specific to women. They're Women's Preventive Health Services, and the task force was pointing to women of that childbearing age ending at 46, as we talked about before. But that definitely does not mean that we recommend, only responses to women. And so definitely we recognize that domestic violence happens to men as well, and in gay, lesbians, or transgender relationships. So we're actually developing some new resources for LGBT communities as well. But I think it's a good question, and the policy is specific to women, but the practice shouldn't only be.
Actually, Lisa, can I jump in there for just 1 second?
Sure. Yeah.
The health coverage piece is, and who is eligible to receive the financial assistance and to qualify for that DV exemption on the healthcare.gov application, that is not gender specific. That language is specific to victims of domestic violence and abandoned spouses. And I'm not clear which piece you were looking at, but for the purposes of the application, that is not gender specific.
That's great. Thank you for that clarification. Yeah. As I scroll through, do any of the other hosts or presenters have additional comments or questions? Okay. Can behavioral health, looking at this question from Catherine, can behavioral health providers receive payment for screening and brief counseling, or only medical providers? Lena, I might turn that one over to you. Is the coverage requirement, does it include behavioral health?
So here's what I'm understanding that question to be, and I might be answering the wrong question. The screening and brief counseling requirement, the definition of what brief counseling is somewhat narrow in terms of its scope, but it would include certain types of behavioral health. I think the greater question and the greater opportunity here is that these new health plans, both in the Medicaid, the new plans in the Medicaid program and the new plans through the marketplace, do offer comprehensive behavioral and mental health coverage. And thanks to the mental health parity law that just passed, the mental and behavioral health services need to be offered in a similar manner to medical health services, which means a greater range of services at a more comprehensive level are now available through these plans. Clearly there are limits to that, and those will vary dramatically state by state and plan by plan, but some baseline of coverage is available through them, which opens just a lot of doors to being able to access coverage and for providers to get that reimbursed. Lisa, do you think I sort of answered that appropriately? Am I answering the right question?
Yes, I think so.
Okay.
Maybe the person who questioned it, you can enter into the chat if you need more, but that's how I understood the question as well. Okay. Let's see. I don't see any more questions. I see some great chat about some of the exciting partnerships that some of you are working on in your communities, and I love to see that. Just want to, again, remind you that the resources are available to you through Futures Without Violence and our Health Resource Center on Domestic Violence, and specifically this online toolkit was created specifically to help providers and advocates work together to respond to the new ACA and task force recommendations. So do take a look at that. If you have any trouble navigating the website, let us know, but do take a look at those resources that are available to you that include videos and provider materials and patient materials, training, tools and a whole host of policies and procedures that including those around keeping medical records as private and safe as possible that are available to you. And we always welcome feedback from the field about what's useful in those resources and what else you need to do this work well. And with that, I'll turn it back over to our host and to thank you so much for joining the webinar.
Thank you, Lisa. This is Shondell Dawson, Senior Program Specialist with the Family Violence Prevention and Services Program. I would like to thank everyone for such an exceptional webinar. We really appreciated having the expertise of not only Lisa but Lena to help us understand not only the public health aspect of domestic violence, but what does this mean for addressing this issue within the healthcare setting? What is the context for understanding this as it relates to the Affordable Care Act? And so I want to thank you both for sharing your time and expertise with everyone this afternoon. I'd also like to thank Jen and Aaron from the National Center on Domestic Violence, Trauma, and Mental Health for making this webinar run so smoothly. We couldn't have had such a smooth transition without you all, so we really appreciate the time and effort today. Mary Louise and I would both like to thank our partner, Sabrina Madoff-Stepp from the HRSA Office on Women's Health, for their leadership and commitment and investment to raising awareness across HRSA programs about the impact of domestic violence, the importance of partnerships with community-based organizations and domestic violence programs, and for their support in spreading the word and raising awareness about the great tools and resources that have been developed by the Health Resource Center over the last 16 years. And lastly, I'd like to thank all of you for making time today, for help spreading the word, for connecting others to the healthcaresaboutipv.org website, as well as for sharing tools and resources on the ground and building stronger partnerships within local communities. As we mentioned earlier today, the webinar recording and the slides, as well as the new FAQ documents, will be available on Future Without Violence's website. We will follow up with an email to everyone who attended the webinar today to ensure that you're notified of when that posting is available. And at the end of this webinar, we'll ask you all to take a very brief survey to help us understand what was useful and what could have been better in terms of the webinar that you all participated in. And we really appreciate you taking time to make that happen today. So I want to thank everyone again, and we hope that you all have a great afternoon. Thank you.
Thank you.
Thanks, everyone. This is Jen from the National Center. We'll leave the chat open for a few more minutes if people have a couple more questions or any comments, and then we'll shut the webinar down. Thanks, everyone, so much.